So the next speakers, we are very honored to have Professor Kumarasamy from India. He's internal medicine and have an expert, have training in both in India, in US, in London, and also he is the chief and director of VHS-Infectious Disease Medical Centers, a clinic which provides medical care for more than 20,000 persons living with HIV in southern India. And Dr. Kumar have broad experience. He can treat anyone from baby, adolescent, young adult, or even elderly. So I think he's have the whole spectrum of clinical care, and we are very honored to have Dr. Kumarasamy talk about challenges in providing treatment and care for adolescent and young adult. Thank you.
Good afternoon. At the outset, thank you, Dr. Tanavi, Dr. Kulkarnia, Dr. Anjali, good friends for decades, and all the organizers for inviting me all the way from Chennai to do this talk. So we had very brilliant presentations in the previous sessions, all hardcore science. And now what I'm going to talk to you is, what are those challenges you're going to face in implementing those hardcore challenges, particularly in the population of adolescents and young adults. I'm basically an adult physician, but my clinic also take care of a lot of adolescents and young adults which are transitioned from care from the pediatric population. You saw this map from this morning that these are the new infections which are reported by UN-AIDS. And again, if you see in our region, it's around 300,000 new infections last year alone. And out of those, if you look into the math, 23% of all the new infection globally is from Asia Pacific. Again, if you further cheese this down, almost 1 in 5 of the new infections are in adolescents or in young adults. So we call it as AYA, like adolescents and young adults. So this is going to be very alarming. So now this is going to become an important field of medicine in HIV because of how you're going to take care of these adolescents and young adults. Not that easy. Now we have science, how we are going to implement on them. Again, data has very clearly have shown the lower rates of testing in this population and also treatment engagement, viral suppression than adults. We can talk about sophisticated science from clinical literature, but how we are going to implement in this population is important. As many of you know that many of them might be pediatricians, and they are a very unique population. In terms of developmental, psychosocial, behavioral, infrastructural factors, these are all affect this vulnerable population. When you have good science, I think we also will have challenges how to implement on this. Without having specific challenges that needs address, it's going to be a monumental task to implement all these guidelines, particularly in this vulnerable population from our practical experience. And we have seen they have poorer HIV-related outcomes in this population, and including persistent viremia, drug resistance, morbidity, mortality, and as well as secondary transmission. If we don't address the challenges, whatever good guidelines we have, very hard to implement on this. I'm going to divide this AYA, adolescents and young adults, into 2 categories. One is those who have been acquired HIV in the first decade, and now they move into these adult physicians. The other population is people who have been newly infected now after their second decade of life. Again, these 2 populations are very important in terms of management. The first one is they are being heavily ART treated, starting from very younger as kids. So now they might be on first line, second line, on salvage therapy. And the second population is mostly ART naive. Now take the second population first. We all talked about ART, we all talked about dolutegravir, all about resistance. Don't forget about opportunistic infections. Data again clearly shows that if we don't diagnose these opportunistic infections, starting from TB to various OIs, in this population, the risk to progression to HIV disease is much quicker than in adult population. This is something that's already been reported. It's very, very important. It can go unnoticed, and literature has come from very observational studies. It's very important if you are a treating clinician, adolescent and young adults, look for these advanced HIV disease guidelines. If they are present with a very low CD4, implement this first before you think about any antiretroviral therapy. It's very important to manage them, for these opportunistic infections and prevent them. Now, coming to antiretroviral therapy, it's very simple. Now we have very simple guidelines thanks to WHO. Our regions can very easily implement. We got one regimen for first line, one regimen for second line, and one for third line. Very simple. even good trained nurses can do. But implementing on them in our population is the most difficult. We have rapid ART, immediately you have to implement, and the same day ART. How we are going to do this in a population where they even do not know whether they have HIV or not? If you look into the first population, when they are being moving from the pediatrics to adolescent care, they may not even know. The first thing I think we all do is talk to the parents whether they know about the disease. So they say they do not know, don't tell them. So again, if you're going to talk about all these antiretroviral drugs to them, they're not going to take it unless you disclose anything with them. And also, even if they know about that, they have a different challenge in adherence. Many of them will be going to the schools, or they are away from the home. Till that time, they have been pampered by their parents for everything. When they're in a college or in a work or in the early part of their career, so hard, for them to adhere to these medications because they are away from their family. Again, as a clinicians, you have to spend a lot of time how you going to engage them in take care of these issues. Drug-drug interactions, these are a very young population. They might be on contraceptives, they might be on various other substance abuse, and as well as other medication. There are very little clinical trials which have addressed this, particularly in this population. And very importantly, before we talk about any care to them, counseling on new informations on treatment, because these young adults, they're so sophisticated in social media and getting informations. So they get all those long information. As a scientist, as a scientist physician, your job is to give good information to them and continuously update them in every times when they visit your clinic. Very importantly, with their mental health. When you have been discussing about them, they are depressed because their peers have been healthy. They are not taking any medication. They're going to be there. They're going to be depressed. How are you going to involve them? Do you have any specific counselors who can take care of them? Do you have any specific procedures to do that? Some proportion of them can be substance abusers. How are you going to engage them in the care along with antiretroviral therapy care? This is something what you have to spend a lot of time, put them in there. If you don't do that, our guidelines are not going to be meaningful to them. And STA consideration. Today, emerging syphilis is very common in my country, in my clinic. So this is something what you're going to do with them. Again, I think there's going to be a debate tomorrow which should be watched by everybody. And their partners might be on PrEP. You heard a beautiful talk. You have to speak to them, these young adolescents, about this PrEP, when their partners are going to use this, how they should make sure that their partners who are uninfected should use PrEP even when they are on antiretroviral therapy. And in my country particularly, these young people, one of the major things is on childbearing and fertility disease. So again, a lot of things what we talk to them about you is equal to you. You take the drugs well, you are undetectable, you can get married, you can have negative children and all that. This is something culturally specific. I think these are some of the things should be addressed, which will be another extra boon for them to take antiretroviral therapy. These are some of the things we use it in our clinic to improve adherence, particularly in this population. Now coming to this antiretroviral treatment, what are you going to for first line? It's very simple. We have got one regimen. TLD, you heard this again from this morning. Very easily can give, but children and neonates, you have got other regimens. And in the DHSS guidelines in Western countries, they also been using bictegravir, which they have data, and as well as with the TAF, which I'll talk a minute on that. You again heard this from the earlier speakers on the Odyssey trials, where they very clearly shows that dolutegravir-containing therapy is much superior than efavirenz, and as well as for second line to boosted PIs. It's been very clear, from all this data, which I don't want to go into the detail just for want of time. And also, studies have shown TAF, bictegravir, and FTC, is been, good in population, both in children and adolescents, based on this study. Very clearly shows that the viral suppression has been able to maintain over a period of time, over 48 weeks. And also, there is no significant adverse events to bictegravir or to TAF, and been well tolerated. And following this, it had been part of various developed world guidelines. Now coming to this population, when I talked about who have been moving from children who have been infected, now moving to from the first decade of life, to these adolescents and adults with HIV, they are heavily treated, either with monotherapy in the past or two-drug therapy or whatever regimens you had, they are heavily treated. So again, your job is how you are going to salvage them based on available data. Either use resistant testing, which is shown from the earlier speakers, or speculate what could be the possible mutation they would have got. Because many times when you do resistant testing, they will not show the mutation because they all would have been archived. They don't have a drug pressure. When you do resistant testing, they should be on the drug pressure. Unless you do a deep sequencing, you'll not be able to do this, or a phenotyping. The one genotyping, what we do, may not be able to pick up those mutations. Again, it is very simple. Our earlier speaker argued, should be recycled tenofovir to tenofovir. Yes, Nadia study, and on Friday I will talk about another one of our study called DEFT. Very clearly shows that we can again recycle. Same thing you're going to use in an adolescent if they are all moving from children to these adolescent, young adult HIV carrier. And again, whatever things what you're going to do, don't forget about improving their adherence, and also talk to them about disclosure. If you don't do that, you can have second line, third line, long-acting injectable, any type of medications, all going to develop a resistance. Again, this engaging them into this particular type of care is more important for this adolescent. Today, we do have a beautiful guidance from WHO on viral load. Earlier guidelines were a little messy on this. Now we have a very nice one, very clear one. Again, this has got a lot of importance, especially for young adolescent and adult, because they would have been on NNRTA containing therapy in the past. If they have a viremic, don't do any meddling with them, immediately switch them to the second line based on these guidelines. So this guidelines very clearly shows that, and also we do have a WHO public guideline for second and third line regimens. We heard a lot about tenofovir. Again, we all know that what will happen to them. This is data from our clinic, where what tenofovir does to our patients. The cumulative toxicity is almost from 5.6%. And in our Treat Asia cohort, which many of the investigators are here, what we have really shown a similar prevalence of renal toxicity. And following this, we do have guidelines. We have to do a creatinine monitoring, initially, and after that, every 6 months, then annually. Now, this is something, again, it's going to be very hard on a long run. Again, putting young people to a kidney toxicity and again managing a kidney toxicity is going to be a so expensive affair and a monumental task. And also, data have shown tenofovir on a long run in adult population and as well as an adolescent can produce BMD loss. They can end up in bone mineral density loss, and thereby you're exposing these young adults to osteoporosis much earlier by giving these drugs. Now, we do have guidelines from the West, clearly shows that TAF containing regimen is safer in children and as well as in young adults, where a 15 milligram is recommended. It's been available from generics. I think we have to advocate, as said by Dr. Prapan this morning, as a doctor, how you can advocate to a program to get this type of medication so that it will be helpful for our adolescents and young adults, thereby they won't be morbid with these medications. We heard a beautiful lecture on two-drug therapy from our friend Chuck Hicks, while we have been having our food here, on various different strategies on two drugs. This is something what we should think about in adolescents and in young adults. This is a population will be benefited. If they are already virologically suppressed, we do that. We have already started doing in our clinic. In my clinic, I have generic two-drug therapy available, 3TC, DTG, where you can see this. I don't want the innovators here to be angry with me because that drug is still not registered here in my country. So this is something what we are already been doing on suppressed young adults. Put them on two-drug therapies, thereby we can save their kidneys, save their bones, and immediately repeat viral load within 2 to 3 months. But we make sure that they are hepatitis B negative and not on TB medication. Now, these are some of the strategies where we can do, but we may need more and more data, particularly in this population, on this type of regimens. We heard a beautiful lectures on long-acting injectable as well as very nice quiz and questionnaires, where we voted for that. Now, these drugs are superb now in a certain population, which you'll hear a lot from me in the plenary on Friday. So, where this is every 2 months, but on the other hand, don't forget that the relpivir is an NNRTA. So, many of our children, they are already exposed to this, either nevirapine, efavirenz, they all can have mutations. The relpivir itself is an NNRTA. There is no data shows that in such population, what will be the efficacy of two-drug therapy. So, again, this long-acting injectable of cabetor and rilpivirine will be a question mark, particularly in adolescents and young adults who had been transitioned from pediatric HIV, where again, we may need to look into that. Again, in young adults, again, there could be a baseline resistance to NNRTA, so we may need other class of drugs or another form like TLD, which again, you'll hear in my plenary on Friday. Again, here again, the dose, what they validate is every 2 months. And it's injectable. If you have seen in one of your clinics where you have done any clinical trials here, such a painful injection, where our young adolescent adults will hate to receive this. I'll tell you, they will not come to you after 2 to 4 months for the next shot. Such a painful. I think we need studies if you are going to implement long-acting injectable, something different than intramuscular injection, something like a subcutaneous or a patches or some other preparation. That's the only way where we will be able to implement. This will be a huge challenge, giving this intramuscular such a painful thing, and especially in a buttock where you need such a private space to do this. And these are the studies which are being recruited in adult populations. We need studies on this long-acting in adolescents, where again, we should lobby for such studies so that our population will be benefited. We talked a lot about integrase inhibitor on dolutegravir and bictegravir, but we forgot about this weight gain, which we spoke a lot in adults, but this adolescents. In my clinic, if I prescribe this dolutegravir, if they put on weight by adolescent or a young adult, they'll come and shout at me. They all want to be like a, Bollywood star or, Hindi film stars, like, they want to have that. That's the current trend of our young adults. And again, if they have been giving this, again, this is something what we need to study, particularly in our adolescents and young adults, whether this integrase inhibitor has got an impact on this. We have seen this data from sub-Saharan Africa and in my country in India, and we need more and more data from our Asian population. If it's going to be the case, we also have to work on with them on lifestyle modification, what other remedies we need to do. Already we do have data now coming up on the usage of integrase, particularly in adult population with hypertension, on cardiovascular comorbidities, so on and so forth, which again further need to be studied here. So I'll talk more about this again on Friday on the plenary, where we have this REPRIP study completed and published now, where we have shown that how these statins prevents various cardiovascular and non-communicable diseases in people with HIV who do not have a previous cardiovascular diseases. But again, we recruited 7,000 odd patients in this particular trial, where their age group is from 40 years and above. So again, we need such studies in a younger population, adolescents and young adults, so that whether this data can be generalizable in that population. Now, European guidelines have already recommended, WHO is seriously looking into that, but if you want to use this in the young adults, I think we need our own data and specific trials, particularly on the safety of statins in this population. I won't conclude just saying that as pediatricians, many of you here in this audience, you know that the population what we are going to manage is adolescents and young adults. They are very unique characteristics. They have developmental, distinct, cognitive development, physical development, because they are all population that come from already been infected perinatally, and they are grown up, they are into the second decade of their life. And they have psychosocial issues and various types of other mental health and behavioral health, which you are going to listen from the next speaker. And we also have a few proportion of them can be transgenders, which I didn't talk on that. I think I heard there is some other talk on this, and as well as additional social and environmental factors on this. Not only just on the antiretroviral treatment, on counseling, but also we need to work on various other preventive and supportive long-term health in adolescents and young adults, so that many of those comorbid conditions can be prevented. Now, I'm really going to end stating that how we are going to transition to the adult care. I'd like to tell you that the pediatricians and adult clinicians are entirely different, right? They don't talk each other in many hospitals. So, because adults say, hey, you peds, and peds say that you guys, very little. I think it's very important the adult providers should be knowledgeable about pediatrics. It's very important. If you don't do that, it's going to be very difficult to care this population. And also, consulting and collaborating with the pediatric adolescent HIV care is very critical to ensure the successful transition of these adolescents and young adults with HIV to adult providers and continued engagement in care. And also to assess their behavioral and psychosocial context and their ability to adhere to ART. And also to develop youth-friendly support and infrastructure to reduce barriers to adherence. These are very different population. They love your clinic only if it is a little different and supportive to them. Otherwise, they may not even come to you regularly, they may not even listen to you. So you need to develop certain other things which will be attractive to this population to do this. And also, it is not just a viral suppression. We have got powerful drug. You put someone on dolutegravir containing therapy, within 2 months, all of them will go to undetected level. So it's not the case. So where you have to talk to them about the nutrition, immunizations, about the substance abuse, harm reduction, fertility, co-infections, STIs, comorbids, mental health and stigma, and puberty and sexual dysfunction, and variety of all. So you have to link a variety of your providers to take care of these populations very successfully. In conclusion, you heard from the earlier speakers, ART is recommended for all newborns exposed to HIV. It's very important. Now we have dramatically reduced new infections in this population. And for children more than 6 years of age, it's been recommended with the dolutegravir or bictegravir-based ART regimens is being preferred. And TDF and TAF, that's something, a question, which should be studied on a long run. And we all know that we don't have a cure. But there are a lot of cure strategies are currently underway. There is one such study happening in pediatric as well as adolescent. We need more and more such studies so that whether the reservoirs pattern in these is adolescents and adults is the same as compared to the other population what we have been studying them. And of course, we can functionally cure them. This is something what we all should be able to achieve them by doing all those whatever I said. And preventing NCDs will be the future question. And whatever we do, don't forget, we have got two types of population. One is infected perinatally, another one infected adolescent. Both needs to separate type of care. Again, thank you again for this opportunity and happy to take any question if there is a time. Thanks.